Good afternoon. Welcome to NCMIC's inaugural Naturopath webinar series. We are using the webinars to explore a variety of topics affecting how you practice. My name is Jackie Hellrung. I'm a professional relations representative for NCMIC Naturopathic Insurance Program. Thank you for joining us today. Before we get started, I have a few notes I'd like to share with you. Today's webinar is pre-recorded to accommodate schedules. If you have any questions you would like us to address, please give us a call at 800-952-9935 or submit your question through the Contact Us section of ncmic.com. We'll get back with you to address your questions. Our quarterly webinars will be posted in the Naturopath resource section of NCMIC. Today's webinar is about documentation concepts in naturopathy. I'm really looking forward to talking with our guest, Dr. Mario Fucinari. Dr. Fucinari led a highly successful practice in Decatur, Illinois for 34 years. He graduated from Palmer College of Chiropractic Davenport in 1986. Dr. Fucinari is a member of the Carrier Advisory Committee for Medicare, a certified professional compliance officer, certified physician practice manager, and a certified insurance consultant. He has been presenting continuing ed classes for over 26 years and is a nationwide speaker for NCMIC Insurance, Foot Levelers, and Chiro Health USA. Dr. Mario whittles a problematic subject to an understandable and interesting comprehension of the requirements. Welcome, Dr. Fucinari, and thank you for joining us today.
Well, thank you very much, and welcome to everybody for coming here today. And as Jackie said, I've been in practice, but for many years, and I started when I was 12, apparently. But also, I'm a certified professional compliance officer, certified physician practice management manager, and that's through the American Academy of Professional Coders. So that's where I come from today. And I really like this subject here, and I know I'm weird about it, but the key is when it comes down to it, what we're going to talk about for the next hour is risk management. No matter what your profession is, and I know that there are some states that license naturopathic doctors, and there's some that don't here, and even within the doctors, we practice differently. And they say you put 10 doctors in a room, give them one problem, and they'll come up with 10 different answers. And the key is that we like to think independently, but everything is based on evidence-based practice parameters, number one. Number two, it's also based on the standard of care. And the standard of care is defined as the type and level of care that an ordinary, prudent healthcare professional with the same training and experience would provide under similar circumstances in the same community. And it has nothing to do with insurance coverage or whatever. This here is a mitigation plan for asset management, if you will, okay? And it's just, and whether you happen to have any reimbursement or you do cash, it still applies to cash, okay? And so as I go through the next hour here, I hopefully know, I always work with NCMIC. I've been teaching with NCMIC since 2004, I always work with the doctors, any doctors that I represent. But I remember I went into one doctor's office and I asked to look at his soap notes, and it said 50 times about salt, S-A-L-T, S-A-L-T. And I said, what is that? And he said, same as last time. And I said, you know what, talk to the attorney and just settle the case, because you can't defend that. And so the whole thing that we're going to talk about here today is risk assessment. And even the government says that the most appropriate means of compliance for any covered entity can only be determined by that entity assessing its own risk and deciding upon the measures that would mitigate those risks. In other words, your practice, you see. and the way you practice. And then if I hit one thing here, and hopefully you have a pad of paper and a pen next to you here, if I hit one thing, write it down, because statistics are you're going to forget 90% of what I tell you. Let's all face it, we have gone through for the last year and a half unprecedented times. Okay, we had the Spanish flu of 1918. And I don't know if you know it, there's actually a very good book out called Pandemic, and it's all about the Spanish flu and how people wore masks for 2 years after that. And then after it settled down and it mutated, then people went out and started partying, and the government ended prohibition, and the Roaring 20s was actually due to the pandemic ending in 1918. Well, I don't know if you've ever heard of the H1N1 flu. That is the same virus that caused the pandemic of 1918, which means we're going to be in this for the long haul for a long time, okay? And we know that the treatment that we give our patients, that we render for our patients here, that the services will help with their immune system. It'll help with how they fight disease. But you have to be careful with what you do and what you say. All right. I was asked to do this talk, and sure enough, it was shortly thereafter. This came out here, and this is a screenshot of it right here. Came out, you see, July 14, 2021, woman arrested for fake COVID-19 immunization and vaccine card scheme. California licensed naturopathic doctor was arrested today for her alleged scheme to sell homeoprophylaxis immunization pellets and to falsify COVID-19 vaccination cards by making it appear that customers had received the FDA authorized Moderna vaccine here, okay? And so she was charged with 1 count of wire fraud and false statements. The bottom line is we know what we do for our patients works, and it doesn't necessarily prevent COVID, of course, but the key is you have to be careful with what you promise and what you say. And remember that if it's not written down, it never happened, you see? And that's why we turn to documentation, because you don't want to get in trouble like this doctor did, okay? And, when we look at the history of documentation, I think this is, I thought it was pretty interesting because, the language that we speak in documentation itself here really dates back into the pyramids. Now, this is a true story here. My wife and I, we actually went to Egypt. It was about 11 years ago, and we spent 2 days in Egypt. Yes, we got out, and on one of the tours, we actually got to go into a pyramid, you see? And in the pyramid, when we came out, it was a room about the size of a bedroom there. And in that pyramid, there were records that were medical records that dated back to 2700 BC. In 1792, there's this guy named Benjamin Franklin. You might have heard of him before. He started to use records. Last year, I went to several state parks, and it was very interesting. There are medical records on monoliths there, and what was so interesting, even by those records, here this is, Boomba got killed by a antelope that speared him. That's what it says there, by the way, okay? But next to the medical record, it said denied. I don't know why they said that, okay? But the key is, that's a joke, okay? But the key is that our problem-oriented medical record, or SOAP note as we know it, the father is Lawrence Weed. Now, Lawrence Weed was back in the 60s, and so if you look at his last name and they thought, what the heck are you coming up with? He's the one that came upon that SOAP note, and that's what we use here today as well, okay? So the bottom line is, when it comes to record keeping, the naturopathic doctors should keep clear and concise chart notes, as all doctors do, okay? The record must be legible, orderly, complete, and abbreviations are supposed to be standard abbreviations, and if ever asked for your notes, send a legend of the abbreviations as well. And so that POMR, or SOAP note as we know it, and there's many different things. I'm going to be teaching in Wisconsin in a few weeks here. And there, I literally do teach them about cheddar notes as well as SOAP notes, and C stands for chief complaint, H is for HPI, and so forth here. But you want to maintain those records for typically 7 years from the last date of treatment here. And if you do maintain any records electronically, then a backup and data recovery system must be in place. Now, where's this guy, Mario, coming from here? Okay, this came from naturopathicstandards.org, okay? And so that's what I'm basing part of my talk on here today. The bottom line is, if you're still doing paper notes, which that's fine if you choose to do that, make sure it's legible. I like this cartoon here. The doctors are striking here, but nobody knows why they're striking because they can't read the signs here, okay? NCMIC told me this here. They said that it's better to defend you knowing that you have no records than to know you altered the records. Again, quick story here. I used to be an x-ray tech in my old days, and previous to becoming a chiropractor. And my wife's, she was an ICU nurse and then an ER nurse. Then she met this hot x-ray guy, and everything's history. But the thing is, she said, let's go to up north Michigan, and she wants to see one of her friends. And I go, what, come on, and she said, you can talk to Steve. He's a nice guy. He's an IT consultant. And I go, oh, okay. So obviously we went, because I always, I don't have the control. But the key is that we went up there. And so I remember, like, I'm expecting some guy in a white shirt with a thin black tie that works at Best Buy, IT consultant, right? And I sit down with Steve and I say, so I understand you're an IT consultant. And he said, well, actually, I work for the FBI. I'm a computer consultant for them. And it's like, prayers are answered. There is a God, right? And so the key, we start talking, and at that time, it's dating the first time that we ever met. He had just finished testifying in the Michael Jackson death lawsuit against the doctor there. And he said to me something that was very poignant and that I still carry with me today. He said, when the FBI swoops in and they're carrying out all the computers, and this is what he said, I'm quoting almost. He said, that's for show. My software, when I go in there, I know when the doctor put in the note in the computer, and I know if they changed it, you see? And that's why if you're asked for notes and you don't keep notes then, and it doesn't matter, yes, whether you're licensed or not, you can be sued by anybody at any time, you see? And then writing the same time, SALT, same as last time, please don't use that. That's cloning your notes there. That also is considered to be fraud. All right. Do you ever call your patients up on the phone and ask them how they're doing after their treatment? Okay. Well, do you document that? Because if it's not documented, again, it never happened here. The content of the documentation now, it's not how much you write. It's because garbage in is garbage out. It's what you write. And remember, as I said over and over again, if it's not documented, it never happened. So 33 to 30 or 52% of patient encounters are undercoded if you use CPT codes, if you're licensed, and you can submit any of your services for reimbursement. Okay, and this comes from the Journal of Family Medicine. But the bottom line is that when we look at our consultation here, what drives what you and I do in our practice is medical necessity, okay? Medical necessity is the overarching criterion for payment in addition to the individual requirements of the service, okay? Now, okay, what if they pay cash? Forget, payment, but in the individual requirements of the service, the volume of documentation, again, should not be the influence here. So just to go through and just to review some things, and I know you should do this here, but do you do it? And I'm just going to bring up a few things. Number one, every encounter should list the chief complaint, every single one here, okay? It's a concise statement describing the symptom, problem, condition, diagnosis, or other factor that is the reason for the encounter, okay? Now, in addition to many of the elements that we get, and including the history and everything else, is their family history, okay? Now, first of all, do patients fill out forms properly? No, never, right? Okay. And they write NA because they were left on a doorstep, I don't know, or hatched or something like that. But the key is, the bigger your family, I'm the oldest of 6 kids. My wife's the youngest of 9. We have a large family, right? And everybody is an uncle or a cousin, right? Uncle Guido, Uncle Louis, Uncle Vito, Uncle Dino. I actually have all of these uncles here, and Uncle Tony and Uncle Sal and everything else, right? Okay. And then I find out they're like the 4th cousin of the 2nd neighbor on the 3rd block. I mean, who is family? Well, family itself, our mother, father, brother, sister, the grandparents, both paternal and maternal grandparents. That's what is considered family. And what we're looking for are hereditary factors, you see. When we're looking at allergies, we're looking at systemic changes within the body that may be coming from medications, from vaccines that they've had, from supplements, environmental, seasonal food. And I always put in there latex because, consider, what you're using, even your gloves and everything, make sure it's latex free, okay? When we look at their surgical history, the surgical history, number one, where was your surgery? Okay, when? The outcome. I had a patient come in and he said, well, I had an umbilical hernia and I had surgery for that, but that doesn't concern you, right? And I said, well, actually it might. And I said, did they put a mesh in there, a screen? Yes. All right. When did you have your surgery? 2 weeks ago. Are you under any limitations? And he said, well, yes, I can't lift. Well, that's going to affect the treatment that I do for him. And obviously you want to know if they have a pacemaker and other things like that, okay? Prescription medications as well. Now, when you look at medications, it's really a broad, this has changed over the years, and I'm sure you realize this too. We look at prescription medication here, but over-the-counter supplements, alternative medications, and then they talk about even, recreation. It used to be illegal drugs, and then it's recreational drugs, like, you only smoke marijuana when you're playing pickleball or something like that. But you always want to note the dosage, the frequency, duration, reason, and adherence here, okay? When we look at their past medical records here, their past conditions, any prior accidents, injuries, any prior pregnancies, not only the gravid, pregnancies that they actually gave birth to, but any pregnancies they had that they might have lost, any prior interventions for the problems for their chief complaint, any surgical history, as well as previous hospitalizations here. Because our past medical records here give us complicating factors. And we know that that patient, as an example, if a patient is a diabetic, okay, and they have an A1, I had one come in, he said, my A1C is 13.1, that's because I had pancakes that morning. No, you've been eating pancakes for the last 3 months, that's the problem, right? And so the key is, we know that that patient is going to respond slower to our treatments as well. And then, of course, we have something that very important nowadays, is your social history. Okay, you're married, it's going to take twice as long to heal. No, I'm just kidding, okay? Here we're looking for their lifestyle factors, all right? Are they currently employed, self-employed? If they're retired, what did you do? And I always ask them, like I had one recently, he said, I'm a mechanical engineer, okay? And I said, yeah, but what do you do? And I've had mechanical engineers who work at a factory that are wearing a hard hat, wearing boots and walking around the factory all day long on their feet. Okay, I have others who are at a computer all day. you see. And then again, drugs, alcohol, tobacco would include not only cigarette smoking, but pipe smoking as well as chew. All right. Look at their dietary habits and, whether they eat, 3 meals a day, 5 meals a day, continuous, or, trying to diet or whatever here, their exercise routine. I had a patient come in, and again, God gives me all these just so I can teach it to you. I had a patient come in, and I said, "Do you smoke?" He goes, "No, I quit." And you always ask, "When did you quit?" He said, "Well, 2 days ago." And I said, "Why?" He goes, "Well, I saw my medical doctor yesterday, and I'm seeing you today." And I said, "Okay, when are you going to start again?" He goes, "Probably tomorrow." You see, so the key is that for the lungs to aid in regeneration here, you want at least a 6-month gap in since they last smoked. Okay, and then the level of education, that's really so that you can talk to the patient in a way they can understand here. And then sexual history, we have number 1, HIV and AIDS. I'll put in there even put in Hep C, because those born between 1945 and 1965 are 3 times more likely to have hepatitis C. And by the way, that's because of the Vietnam War, because vaccinations, they use the same needle. Okay, people with tattoos are more likely to have hepatitis C as well. Social factors, here we're looking for social factors such as perhaps they are in the LGBTQ community. And so there are some stigma as far as getting their treatment here. And also don't forget to ask the patient how they wish to be addressed. All right. Some patients they consider themselves to be non-binary, which means neither male nor female. I've had a patient, and that patient said, "Refer to me as they." It's like, okay. As I stated at the beginning of this class here, we've gone through a huge change in our society with the pandemic, but don't forget there's another pandemic as well with opioids, okay? And, the coronavirus pandemic here and the loneliness and disconnection from social distancing has led to an increase in opioid use, okay? At my age, you tell me to take a time out, I'll say, give me a book, can I take an 8-hour timeout, right? Younger people, my daughters are in their young 30s, and that emotional toll has taken effect on them because they don't, at least last year, didn't have the social interaction that they used to have. Okay, here's a statistic that you may not know about here, but this came from just in July. It was released here. 93,000 people died of drug overdoses in the United States during the pandemic in 2020. And this is, quote, a staggering loss of human life. I think we can all agree with that. Roughly 21 to 29% of patients prescribed opioids for chronic pain misuse them, and between 8 and 12% develop an opioid use disorder. In fact, most of your patients that misuse prescriptions, opioids, eventually they turn to heroin. Why is that? Well, if they can't, if they have to go to buy drugs on the street, a hydrocodone or other drugs there can cost as much as $80 a pill. Heroin is $10 a shot, and so about 80% of the people who use heroin first misuse prescription opioids. Okay. Many of you, myself, many of our patients, and even children are working virtually now, like I'm teaching here today. And keep in mind, again, their daily habits here, are they sitting all day? Sitting is more dangerous than smoking, kills more people than HIV, and is more treacherous than parachuting. We're sitting ourselves to death. By the way, that was written by Dr. James Levine from Mayo Clinic here in Arizona. He invented the stand-up desk. All right. But the key is that the evolution of patients, and I noticed one time, and maybe you'll notice here, that the size of the patient is inversely proportional to their monitor, okay, when you look down here. But, I recently talked to one of my patients, and he was in his late 30s, but he told me he sits 45 minutes driving to work. He sits at work 8 hours. He eats his lunch at his desk, and then he drives 45 minutes back to work. And I said, well, what do you do once you get home? And he goes, I sit and watch TV till I go to bed. So he's sitting his life away. Sitting is the new smoking here. In fact, the studies, many of them out there, the one study published in the American Journal of Epidemiology found men and women who sat more than 6 hours a day died earlier than their counterparts who limited sitting time to 3 hours a day or less. And you and I know, perhaps in their business, their place of business, they may have ergonomic setups here, but do they have that at home as well? And so if they're working from home here, you want to talk to them about the ergonomic setup. And I always talk about, using the back of the chair, which we're bad at, right? And how the head should be in line with the shoulder, with the hip here. The femur down here should be parallel with the floor. And remember those little armrests, those little baby armrests there, those are actual elbow rests. And when you, try it here, when you sit up straight here, are your elbows coming up, and those elbow rests can actually come up and just put a little bit of pressure, taking pressure off of the shoulders, the traps, and of course the neck region too, okay? And then the elbow, 90-degree bend at the elbow, 0 bend at the wrist here, okay? So talk to your patients about, that aspect as well, okay? Also, before we used to say, have you been around with a person with COVID? All right. You go to the grocery store, there's probably somebody there with COVID right now, right? We don't know. But the key is, have you yourself, the patient, had COVID? Because we know now that the symptoms of COVID infection lingers months after the diagnosis. In fact, we're seeing, and when I actually consult other doctors in practice, and we're seeing many more patients coming in with they call it long haul COVID, which includes brain fog. It's a cognitive dysfunction, headaches, and fatigue as well here. More than 50% of healthcare workers infected with SARS-CoV report that their sense of smell has not returned to normal even 5 months after the diagnosis of their infection here. And so that loss of smell is very prevalent here. If the patient seems like they're in a fog, I mean, literally here, that's the brain fog caused by the cytokinins and the inflammation that they have from the COVID here. So, and even after symptoms of SARS-CoV-2 decrease, and now we have the Delta variant, there's actually at this time here, you don't hear it on the news, but now it's the Beta variant as well here. So again, look for some problems with ataxia and with loss of smell, loss of taste as well, and don't want to miss that in your patients as well. Okay, so we always do, you and I, we do the HPI, and I always teach the HPI, history of present illness, as LMNOPQRST. Number one, where is the location or the region of any symptoms that you have? Is there a mechanism of injury, or what modifying factors have you done maybe, okay? As far as, I mean, in my office, the uniform is typically, slip-on shoes here, and maybe, sweatpants here because they can't bend over to tie their shoes, right? When the onset, duration, frequency, provoking palliative factors, any interventions here, quality of their symptoms, is it sharp or dull or stiff or achy, radiation severity and time here, okay? Now, 90% of the diagnosis comes out of the patient's mouth, okay? And so you and I know that patients don't fill out forms properly. And so I always review with them in what we call the review of systems, okay? Now, the guidelines state that, excuse me, I want to take a drink here. The guidelines state that if a patient does a checkbox of symptoms, that's considered to be a past health history, but you and I know that they don't fill out forms properly. And when we ask them, that's called a review of systems. A review of systems helps us with that differential diagnosis. And the categories of review of system: history of, complaints of, denies. Well, how many different systems do you have to review? Okay, there are many different systems as you see here on this slide. The answer is what's ever medically necessary. So, I like to look at, depending on their problems, any problems with rash or itching, especially if I'm dealing with a nerve problem. Why? Because of shingles. Okay, COVID, any dizziness here, any post-concussion syndrome from injuries they've had here, vision problems and so forth. Okay, so the key is you want to write that down, because patients don't give us the proper information on their forms here. Why do you do this? Because once you see what the patient wrote down, you analyze it, and that's called medical decision making. Medical decision making is the primary element in your examination, your evaluation and management. Whether you're billing a CPT code or not, medical decision making, which is our thinking, really, that's what rules the whole treatment, the diagnosis, treatment plan, and so forth here. Medical decision making is defined as the process of establishing diagnoses, assessing the status of the condition, and or selecting a management option. So the key is, you and I, it's kind of like breathing, isn't it? Okay, I mean, if you think about breathing, your breathing rhythm gets all messed up, right? It's just, we do that automatically. And just like when a patient is talking to me, I am automatically deciphering everything they're telling, and I'm thinking, what could it be? What, rule it out, rule it in. What's the differential diagnosis here? But now we have to write that down. You see, documentation, okay? Our SOAP note, I'm not going to spend a lot of time on SOAP note, but SOAP, I always think for the S, I think of Marvin Gaye, okay? And his song, Talk to Me Sister So We Can See What's Going On, okay? It's a great song, by the way, look it up, okay? So, the SOAP, the S in SOAP note, we know our patients. Tell me, put me in the encounter, their pain, limitations, any concerns, problems, anything that we cannot measure or verify. It's what the patient, it reports what the patient says here. It could be a quote, you can summarize here, but it's basically like an interview, okay? And then when we do objective, now you're the scientist. What did you find? Okay, so we use our senses, our vision, hearing, smell, touch. Please don't taste your patients, okay? And so again, document that down. Now, probably, in my opinion, the most important element of a SOAP note is the assessment, okay? Because here, doctor, this is where you shine through. What did you think? Your thought process, okay? And really, if you look at the SOAP note, it's like your history, exam, medical decision making. And remember, medical decision making is the overarching medical necessity, and then medical decision making here, okay? So the key is, in this slide here, it should be assessment here. The provider records their professional opinion and judgments. Tell me what's going on, okay? If you think of it like a mathematical equation, your subjective plus your objective gives you your assessment, which yields your treatment plan, you see? And if I told you that the patient has edema, let's just make it easy. Let's say edema of the right sacroiliac joint. Are you gonna tell the patient to use heat or ice? Ice, right? Okay. Can we use diathermy or a thermal patch? No. Okay. How about ultrasound? Okay, maybe in a pulse mode. And I'm being very simplistic. Obviously, you'll have other ways to treat it. But the point is, by me telling you my assessment, which is my medical decision making, then you told me the treatment plan, okay? And that treatment plan basically, number one is based on naturopathic principles, okay? We want to, as a naturopathic doctor, you want to stimulate the patient's vital force to promote the healing, and in special circumstances, supplementing or replacing the action of that vital force here, okay? We want to always, if we can, get to the cause of the condition and either modify it if we can, or remove it if we can as well, okay? And always have the patient's best interest at heart and least risk of harm to the patients here, and individualize. If you find yourself doing the same thing, every patient that walks in the door gets this no matter what, okay? That's not right, okay? Patients' treatment has to be customized because patients are individuals and are unique individuals. Of course, we want to educate. Just like I educate my patients, I educate you, I educate everybody here, because educating the patient helps, it empowers that patient for their own healthcare as well here, and make them an advocate for their treatment, and hopefully we can prevent disease as well, okay? Now, there's always risks and benefits, anything. And it doesn't matter. Again, as I started out the premise of our class here, the premise is it doesn't matter if you're licensed in your state or unlicensed. It doesn't matter if you get reimbursement from an insurance carrier, which typically you don't here. The key is that it is risk management. You see, and that's why you want to, not just want, you have to have an informed consent. And that informed consent will take into account all the factors listed in the patient's rights and ethics, which is do no harm, interests of the patient, come first here, all right? And, those kind of things there. But keep in mind that the informed consent is state controlled. I would tell you, number one, talk to your state, but also, Board of Examiners or whichever for licensing, but also the NCMIC. They are there to help you. I have been insured with NCMIC for the last 35 years. And the key is that NCMIC, you can always pick up the phone and say, what should I do? And if they can't help you, they'll tell you where to get information here, okay? And so you want to provide information about the risks, the benefits, alternatives, and document. If the patient has questions, then document the question and the answer, all right? And, we want to talk about the inherent or foreseeable problems here, but when it comes to informed consent, give me the patient's diagnosis here, the nature and purpose of the treatment, the risk and benefits of that treatment, and I like to give them alternative options. Why? Because those alternative options are typically turned down from what we do, you and I, right, in our scope of practice as well, okay? And again, so when you communicate with the patient, we let the patient make the decision for their own health, all right? We're not authoritative enough that we are dictators for our patients here, okay? And there is some difficulty, granted, with the way we communicate because of COVID, all right? Now, earlier on, I showed you, what that naturopathic, I could show you chiropractic, I can show you medical. I even have one from a pharmacist that was doing illegal stuff pertaining to COVID. But what I want to talk about is the communication to that patient here. We've gone through a paradigm shift in the way that we communicate with each other and with our patients as well, okay? And paradigm shift, by the way, I looked it up, it's a fundamental change in approach or underlying assumptions here. 2 years, 3 years ago, I didn't even know what Zoom was, right? Now Zoom is like Kleenex or, Xerox, it used to be for copying stuff, right? And many of you may be already utilizing telehealth or telemedicine, okay? There's a difference here. Telemedicine is the practice of medicine using technology, such as what we're doing on our talk here today. But telehealth is broadly electronic and telecommunications and services to provide that care, okay? And so really it's telemedicine here, but telehealth is different from telemedicine in that telehealth refers to a broader scope of healthcare services than telemedicine, all right? And telemedicine refers specifically to remote clinical services. So number one, if you are doing telemedicine now or considering it here, telehealth and more specifically here, make sure it's within the scope of practice for you in your state as well. Does your state allow you to provide telehealth? Is there a difference in the rules for any doctors and staff? And make sure you have updated consent forms to include telehealth services, okay? I am not a lawyer. Talk to NCMIC and they will help you with that, all right? Does your current malpractice insurance cover telehealth services? Again, talk to your talk to NCMIC, okay? That's what we're there for, what they're there for, okay? What does each specific carrier require to be documented in the medical record for each telehealth visit, okay? And the key is that documentation is going to save you or drown you, what you choose, all right? And I'd prefer to be saved at this point, okay? So always, again, have a healthcare attorney review all of your policies, procedures, consent forms, and intake forms as well, okay? So number one, just in general, make sure that you're using a secure portal, okay? A secure portal, is Zoom considered to be HIPAA compliant and secure? It could be. Number one, you have to have a specific password for that patient, and sorry. And also, you want to make sure that you can actually have a business associate agreement signed by Zoom for you as well, okay? And that business associate agreement is with any independent contractor. It's basically, if you have a leak of information, then you got to tell me. If I do, I got to tell you, okay? And again, if you are billing to insurance, make sure that you check with that individual insurance carrier of any CPT codes that they may want you to use. Typically for documentation of telemedicine or telehealth here, you want to talk about the location of the conferencing. In many instances here, you want to document where the doctor is located, which is called the distant site, and the originating site is where the patient is located. Very importantly here, the doctor must be licensed in the state where the patient is located. All right. One of my friends from Illinois just recently moved to Tennessee, but she's still practicing in Illinois through telemedicine, you see, and she is licensed in Illinois. So the key is it can be done, and is being done on a daily basis here. So again, some of the documentation, date of service, location of the provider and the patient, name of the participants here, is the service in real time, or is it taped, or the start and end times. Everything is based on time as well, and make sure that you give the medical necessity for it, all right, whether it be due to infection control or due to the patient's circumstances as well. And make sure that there are, it's like, if I'm wearing a mask, you cannot always maybe hear me properly, but also see what I say, all right? And your body language makes a big difference here. And so that emotional expression, like a smile, comes through from our eyes, all right? And so the corners of the mouth turn up, the laugh lines appear here, and we know we're smiling as well, okay? But emotions of fear and surprise actually don't come through if you're wearing a mask, okay? And so that's why maybe a patient can't read us all the way, but maybe we can't read that patient. And so there are advantages and disadvantages of telehealth as well. And again, make sure that you have proper privacy practices here. And if you're using a HIPAA notice, here is this notice describes how medical protected health information about you may be used and disclosed and how you can get access. That is word for word that has to be on your HIPAA notice. There's no exceptions to that. That's controlled by federal government, but also telehealth services as well. You know, if you are doing telehealth, keep in mind the circumstances of the patient, okay? And that's why, you know, when you want to look at discrimination awareness, I mean, you and I, we grew up, I'm sure, you know, back in 1964, it said the government passed the Civil Rights Act of 64 that says that you cannot discriminate based on gender, race, or national origin. But as Paul Harvey would say, and now for the rest of the story, in 1975, they actually added to that, they did an addendum, which is for age-related discrimination, you see. And then Section 1557 of the Patient Protection and Affordable Care Act here says that that discrimination based on race, color, national origin, sex, age, or disability is forbidden. And sex is pregnancy, but it's also sexual orientation or gender orientation as well here, okay? And so that's why when you think about Section 1557, what is their religious preferences? There are religious groups there, the Amish as an example, that do not allow video. There's certain groups in the Jewish religion that do not allow video or showing in their home and video of any type here. And so are you discriminating based on the type of service you are providing through telehealth? You see, and that's why, you know, you want, as I stated earlier, you know, you want to take into account the sexual orientation of a patient. Why? Because part of that is they have unique circumstances as well. Of course, disability, based on disability, either for employees but also your patients, can they get access to you if you're on the second floor of a building and there's no elevator, as an example, okay? And then, of course, as I said, with age, it is required in most instances to have some type of notice of non-discrimination. And here's our office does not exclude, deny benefits to, or otherwise discriminate against any person on the basis of race, color, national origin, disability, sex, or age in admission to or receipt of the services and benefits. This was written by a lawyer, not by me. Okay, it was actually in courses that I have taken through the government. Okay, so, you know, the bottom line in this short talk that we've had here and is that documentation serves many purposes. Number one, documentation shows it's an accounting of the encounter. Say that 5 times. It's an accounting of the encounter. Whatever happened. It's the legacy. You and I are mortal, all right? We may not be here tomorrow, and if we're not, then somebody else can take up our, you know, in our footsteps here to take care of our patient, because the patient comes first, number one, okay? Number two, it's risk management. Because if you discuss something with the patient and you know, lawyers, the first thing they look at is an informed consent. Okay, and so you discuss it with the patient and the patient declined the treatment, then if it was that important, why did you continue to treat the patient? Maybe there were other alternatives that you and the patient decided to forego or to the route to take here in the in between time. So the bottom line is that the patient has to be empowered, but you have to document that as well, okay? And so hopefully together we can take care of the patient properly. And you know, risk management, again, you're not going to be at risk for any loss of income or your license or so forth. Okay. All right. So hopefully that seemed, if you got one thing, it helped out fine. Okay. Now I know in our format here, it's hard to ask questions if you have it, but number one, my email is doc, at askmario.com, doc@askmario.com. But also, you know, feel free to call NCMIC. I have frequently, you know, I'm a teacher and, you know, I'm supposed to know it all, but I don't. And so I'll call up NCMIC and I'll ask them as well, okay? So I thank you for your time and your attention here. I'm going to turn it back to Jackie and let her take you from there, okay? Thank you.
Thank you so much, Dr. Fucinari, for presenting today. We really do appreciate it. It was excellent information. There is one question I'm sure that might be, I can anticipate coming through, and that is, does NCMIC include telehealth in their policy? And the answer is yes. If you are practicing telehealth, telemedicine, you call us, let us know. As long as you are licensed in the state in which you are treating in, as Dr. Mario suggested, then yes, you would be covered. So just wanted to put that out there and make sure all our policyholders are aware that we do cover telemedicine. Again, thank you so much. Excellent information. I want to say before we go that we are continually adding to our content with information to help you navigate daily practicing, and also the challenges you may face at this time with COVID and anything else that might be coming up. So we have a lot of information on our NCMIC naturopath website. Please take a look at it and check it out. We're here to help you. If you have any questions, again, please feel free to call in and ask us. Or if you have a question for Dr. Mario, please go to his website, or you can email him directly as well. Again, thank you. You can find us on Facebook, Twitter, Instagram, and LinkedIn. And I really appreciate you again for your lecture today. Thank you and have a wonderful day.
Thank you.